the indications of US guided liver biopsy, liver segment, we have had discussions with different faculty over the last 2 days, different way of demonstration, different way of identifying liver segment. The question is, there are many questions why US guided liver biopsy. Is it more safe? Indications, not indications. But I think some of them have been answered during the workshop. As I personally would like just to tell the audience that when you're talking of liver segment, we have to broadly in our mind divide the liver segment into above hilum or below hilum. The above hilum liver fragments are 7842. 7842. So the 7 segment, 8 segment, 4 and 2 segment, 4A. And then the lower segment are below 2 is 3, below 4A is 4B, 3, 4, below 7, 8, 8 is 5, and below 7 is 6. So you imagine a line. So upper segment and lower segment. So the upper and lower segment are divided by an imaginary line which goes through the hilum of liver. And that is why Dr. Rajendra Prasad has shown how to identify the hilum of liver. It is important to identify that we have liver segment. So to identify upper liver segment, to identify lower liver segment. Now, which liver segment you will do FNAC by liver biopsy from? I would say that liver biopsy from caudate lobe is definitely a very interesting proposition. And I would say probably I will do liver biopsy from a caudate lobe unless there is contraindication, because caudate lobe comes in between the IVC. So caudate lobe liver biopsy, the caudate lobe is lying closest to the liver. So that is one logic I have to which segment I want. Now, what is the other segment? The other segment I can do liver biopsy are segment 2 and 3. So, Dr. Kapil, you have to add, but you start the procedure. I will keep on theoretical discussion. You concentrate on starting the procedure because we don't have much time. So, you start the procedure. So, we will be starting the procedure. So, can you present the case?
Middle-aged female having recurrent transaminitis, no other autoimmune manifestation. Her SGOT is 58. Her SGPT is 76. Viral markers are negative. ANA through IFA is positive, 1:100. Cytoplasmic pattern is present. ASMA anti-LKM, other markers are negative. IgG is elevated, 1900 something, not more than 1.5 times of the upper limit. So plan for her today is to get a US guided biopsy done to rule out autoimmune hepatitis.
Okay. So we are talking of autoimmune hepatitis in the case. So Kapil, you have got 20 minutes maximum to do the case, because 4:30 we have the lecture of Dr. Anand Sahay, and 4:30, and then the last lecture is by, of course, by Dr. Kapil Jamwal himself for US in portal hypertension. So you got 20 minutes to show where from why, where, and how you are going to proceed with the liver biopsy. Start the scope, and what the needle that you are going to choose would be the 19 gauge needle. Shark core. Yes, okay. Yes, 22 gauge shark core. Or 19G Pro core. So he prefers Pro core. He prefers 19G Pro core needle of Wilson Cook. Okay. So the needle is finalized. He's going to use 19 gauge. So is Dr. Itish Patnaik here? No. Itish, can you please help in this case? Moderate, put on.
Yes.
So this is the spleen we are saying.
So I have just entered just below the G junction. So my scope is rotated anti-clockwise. So you can see the first structure we see is spleen. and we are seeing that it's not coming into the normal skin. That means most likely it's enlarged. And we are seeing that too many of collaterals or any lesion in the spleen. Then we rotate it clockwise from the same position, and we can see then the left lobe of liver. So this is the liver. So looks fatty because it's very bright on appearance.
So do you have the Fibroscan report of this patient?
Hey, can you change the maybe the
Okay.
bit of okay. No. So maybe the contrast a little bit. Or yeah.
So here LSM is 8 kilopascal.
And cap.
And what is the cap value? Do you have 320 is the cap value.
Okay.
So
looks
it's
fatty.
a F2 fibrosis.
Yeah.
And
Fatty
so what do
liver.
you,
And we can
fatty
see
liver.
in between we can see there's a probe. Yeah. So we can see that the focal fatty sparing in between. We can see the areas adjacent to the
yeah.
probe. You can see there's a hypoechoic area in between. So this could be a focal fatty sparing. And normally we do biopsy from the left lobe of liver, and it's segment 3 mostly because we take the biopsy from above the left hepatic vein branch. So if it's below, then it's segment 3. So this is most likely. We can see the structure here. This is the left hepatic vein, above its portal vein, and this is the left lobe of segment 3, and below this is segment. This is segment 2, and this is segment 3 below. So we take normally biopsy from the segment 2 of the liver, and we can see the hepatic vein is going down deep into the liver parenchyma. So we'll see the vascularity before we see. So what is the benefit of EUS over normal conventional liver biopsy? Is that first we can assess portal hypertension in addition to normal liver, what we see with an ultrasound. So we can see the varices, we can see the portal vein diameter, we can see the spleen, we can see assess for ascites and any lesion in the liver which can be missed with a normal ultrasound. So we can assess with one imaging everything. With the advent of portal pressure gradient monitor now catheter available outside India. So I think with the same setting we can do assess the portal vein pressure also. So that will help in guiding the treatment. Also, we'll take a biopsy along with it. So any comments from you, Itish?
So one question, does she have a portal hypertension? Number one. Number two, before biopsy, doing a biopsy, will you assess for the portal hypertension and look for the architecture of the liver and also for collaterals?
Let's remove the, yeah, okay.
And third thing, to assess for ascites.
Yeah, so normally what we see, if there's some perihepatic ascites, we should be able to see. So we can see the diaphragm below. So, yes, so we can see the atrium, the left ventricle and the liver here. So this is the diaphragm in between it, and we are seeing there's no ascites. So normally when we rotate the scope, we should be able to see some part of ascites if it's available in the perihepatic area. So in this, we're not able to see any ascites at the moment. Then we go for the spleen. Spleen already we saw it's enlarged. So when I rotate anti-clockwise, so we can see that the spleen was already enlarged. This is aorta. So I'll rotate a little bit more to push the scope down. And when we rotate a little bit more, we can see that the spleen is seen. And I could not see any ascites there also. And the spleen size is enlarged. So can you zoom out? Yeah.
Zoom out.
So you can see the spleen is not coming in even after great magnification. So that means it's enlarged. So we can measure it grossly. So yeah. So it's more than 11 millimeter in this axis only. So that means more than 11 millimeter. We are not able to measure. So she has enlarged spleen. Second, we will see is the portal vein diameter, which we can either see from the hyla or we can see at the level of pancreatic head. So when we try to trace it from the hyla, you can see that the portal vein vessel we can see in the center. So this is the portal vein here. Remove the Doppler.
Doesn't appear to be dilated.
Yeah, so let us see. We'll measure it. So it's around 11 millimeter. So that's normal at the hyla. So she has intermittent like spleen in that, but she doesn't have a dilated portal vein at the hyla. And our plan is to do a liver biopsy. So this area looks okay. So this is mostly a avascular area. Yeah.
So what about the margin of the liver?
Margin
And
looks,
texture?
yeah, echo texture looks okay. It's very bright. That means fatty liver is there, and margins are not wavy or irregular. So it doesn't look like a CLD on EUS. Now I have to find, because this is I'm little up, so this is we can see a part of branch of hepatic vein here and a part of IVC. So I'll just push it in between and go toward the deeper segment of liver. So here we see a avascular area. And when I see my arrow, so my needle will be coming somewhere like this.
We have needle data.
Okay.
So from
Yeah.
From which segment you are planning to
So
take
most
liver
likely this is
biopsy?
segment 2. So we'll take a biopsy from segment 2. So you can see that the needle path, which is shown by the marker in the US machine already, it shows the avascular area. So this is the benefit of a US, because we can assess a good area, avoid vessels, and take a good biopsy.
Now the question is, you are not finding features of cirrhosis in this patient.
Yeah.
So which needle are you going to use? It is 22 gauge or is 19G needle?
So all the data is suggestive that 19G can be used. It's safe, effective, and good amount of specimen is obtained.
Because in cirrhotic, the tissue in 22G is be more fragmented, thin.
Yeah.
So difficult to comment about the fibrosis part.
Yeah.
And but in this patient, the pretest probability of getting nodularity and all fibrosis chances is less.
Yeah.
So are you planning with 19 or 22 now?
90.
19G.
90 now.
We don't have 19G, I think.
It's
We have
20G.
20G Pro Core from Cook,
Yeah.
which is forward bevel. Ecotip Pro Core needle. So we have 20 gauge needle. Don't have 19G. So I think in this patient 20G will be fine.
Yeah.
So and what technique are you going to use? Dry heparin, wet heparin suction or conventional suction, and how many passes and how many actuation?
So I think I'll not. The data people use heparin, wet heparin technique, but we use conventional, that we don't use anything. First, go with the stylet, then see the passes, how many passes you make, and see the core. If the core is good, I think that one is enough.
One is enough.
So I'll fix my here. You can see that's a avascular area. We'll see how does the. We can see that the tip is coming. So I'll just draw it a little bit. Fix it here. Use elevator. It will push it down a little bit. Now we can see it going toward the needle path, which we are shown on that one.
So do you use a fanning technique?
We'll see. So I think depends upon how smooth needle is going. So we can use fanning technique, that's already recommended. We can use it. And then, so I'm inside. So I will slowly withdraw the.
So what he is using is stylet slow pull technique for US guided liver biopsy to obtain tissues. And this is the first pass and multiple actuation.
So all the meta-analysis have shown that it is safe, effective. A recent meta-analysis in 2021 showed that it can be compared on the sample size to the percutaneous biopsy. However, the TGLV is superior as compared to the US guided liver biopsy in sample size. So right, I think I've already taken 8 and 10. So let us see how does the tissue come out,
Yeah.
and then we'll see.
So what about the cost compared to US guided liver biopsy and Perkin?
So at this moment, what we see is the cost is little higher because it involves both the EUS as well as the cost of needle. But if you think overall as a endohepatology, so we can assess the varices in the same setting.
Okay.
We can assess for ascites. If there's any problem with the figures, the things coming out. So in the same setting, if we find changes of portal hypertension, we can assess portal pressure in the same setting.
So do you do US biopsy if you're planning for additional endoscopy for any other indications, or you're doing liver biopsy in all patients whenever liver biopsy is indicated?
Yeah. So suppose patient has early portal hypertension, or like this patient who has a diagnostic dilemma. So either we have to see whether patient goes for a percutaneous biopsy if the cost is really an issue. So then I think we can. Otherwise, if the cost is not an issue, patient is affordable, this is the best modality at the moment.
So one thing is clear that definitely the data shows that the pain is definitely less in US
Yes.
guided liver biopsies.
That requires some maybe further, I think,
Yeah.
refinement of the needle and techniques, what
Uh-huh.
would be done. So I think because the needle they use is percutaneous is around 16 G.
16 G needle.
So our smallest is the largest one is 19 G. So that is one issue. Otherwise, I think the safety, the efficacy, and the overall benefit of procedure is more as compared to percutaneous liver biopsy. So normally bleeding doesn't happen because we see it under eye. So suppose it happens, what the IR people do is they keep the needle there.
Yeah.
So either they use gel foam or they use a glue sometimes to embolize the tract. So normally they do use for patients who have a shrunken liver. In this patient, we saw that the liver is okay. It doesn't have changes of portal hypertension. And we see it normally when we see any development of any hematoma, because normally the dreaded complication occurs if we puncture the artery, because venous bleed normally stops by its own. So our worry is arterial puncture or a development of fistula. Okay, it's broken or they're not able to see.
The fragments are there definitely. Okay. Fragment, and so I think the fragmented
as well liver is there.
Yes.
So I think
And surrounded by vessel.
there is a core tissue. Can camera focus here actually?
So you can put it, I think, clear about it. So people have done even US guided what do you say, abscess drainage from left lobe. Now they have with the upcoming, so maybe if is as compared to RFA we are doing in pancreatic lesions.
There is core tissue definitely, but it appears to be fragmented. I think we need to take one more pass.
Can we take
Uh,
the 19
Okay, I think fragmented, but we can see it between
Will be- Yeah.
long segments are also there. So I think it's okay.
It's okay.
Yeah, okay.
So now,
how safely you
no, one more question is, how do you monitor this patient post procedure? And also,
normally-
how do you
yeah.
ensure during intra procedure there is no bleeding?
Yeah, so that's why. So the benefit of EUS is they can see the vessels directly. So we should avoid puncture directly any vessels which is coming in the way. Small vessels can be seen, but if large vessel like there's a percutaneous vessel that is below between the scope and this one, which should avoid. And normally, if we are puncturing it, it should bleed that time only. So normally the bleed is, if it's subcapsular, it should stop by its own. But not the most common cause of the complication is because of the arterial puncture. So that
So-
I think we are avoiding by direct.
Yeah.
direct
So, do you apply Doppler at the track of puncturing
So
after
normally
taking the
we-
biopsy?
we see that because if the blood is there, the field will become blurry. The capsule, which is this point, if we see this area should become blurry, and we can
Blurry.
see a new finding if there is bleeding.
So at present, there is
There's
no
nothing.
signs of
So
bleeding.
it is same what we did prior to procedure.
So definitely post biopsy, you should apply Doppler.
Doppler, we should
ensure
we
that
should remember
it's-
keep the same field in view so that you can compare before and after. I think 5 minutes if you see it's okay. You don't require special precautions like turning on any side. Patient is just like a normal FNA. Patient can go home within 2-3
Okay,
hours. Of
so don't change your field of view.
Yeah.
And my question is, suppose you see bleed in the track, then what will be your plan of action?
So what the US experts advise, they keep a needle for some time. But for me, because the diaphragm is moving, So I think if it's not, if you have done a avascular puncture, chances of bleeding are as equal as that can happen anytime. So keeping a needle for 2-3 minutes in a patient who is already we are subjecting because of cirrhosis and something, it's not advised because it's moving with diaphragm. So I think better is to observe, initially choose a very avascular area, just like a normal FNA procedure. So small bleeds can be managed. Try avoiding puncturing a artery because that is the most common cause of complication because it leads to development of bleeding as well as fistula.
So the most important thing is here, the INR should be less than 1.5.
Yes.
Platelet should be more than 50,000.
Yes, normal, just like a normal
Just
FNA.
like, so there should not be any coagulopathy. So
Yeah.
before the liver biopsies.
Ascites,
And
for beginners, I would tell them to avoid
Avoid.
US biopsy in a patient who has ascites
Yes.
because that time the tamponade effect of the diaphragm will go away.
Go away.
Okay, any questions?
Any questions from the hall? So post-procedure monitoring is very important in this patient. So, already he has told that the practice is doing is just conventional suction and needle 19G biopsy needle. So core biopsy needle 19G. I think two are available. One is Charcot 19G and one is Boston Scientific Acquire
Acquire.
19G Flex.
So,
So
and
at
third is
present,
this cooks.
the cook is 20G. Data on this needle are limited, but they are also promising.